Welcome everybody to Tuesday VMR. It's been a while and I hope everybody is doing splendid and absolutely well. Been difficult. It's been a difficult week, but we are back and hope we can continue to keep the spirit of Rafa alive in this sacred space here that we've been fortunate to learn from and also contribute to. And we're just very excited today to be co-discussing with Kirtan. Kirtan, a long-time friend who has taught us so much and taught us about life and also about medicine, is here to go discuss. And then also a wonderful friend, Shema, Deborah, Umaima, Maddie, everybody's been doing their things, and they each and everyone come back and share their stories and also share in the difficulties of this past week with the tragic news of Rafa passing away. I'm also very delighted that one of my students that I'm working with, Carly, who's absolutely wonderful student, and I'm just excited to have her discuss a case today. She is coming here with a case I have absolutely no knowledge about, so it will be a challenge. And I'll just ask Carly to unmute her mic and introduce herself.
Yeah, hi, I'm Carly. I'm a third-year medical student at Hopkins. I'm planning to apply into neurosurgery, and I'm from New York.
Awesome. And Carly, tell everybody something you like to do, or food, or any story that you have.
Yeah, sure. I guess like one kind of fun fact is I'm a fencer. I've been fencing like ever since I was 11 years old, fenced throughout college. Now retired, but that's kind of one unique thing.
Wow, incredible. You have to tell me more about this afterwards. So
yeah.
I'm just amazed to know about fencing. That's great. And then Kirtan, how you been? You want to unmute your mic and also share in the...
Yeah. Good morning, friends, and thank you for your kind introduction, Dr. Singh. Like I always say that whenever I get time, I try to join this group, because you guys won't believe how many times I bring the CP solvers up during the rounds and during my conversation with my co-residents. I was like, oh yeah, I listened about this when my friend brought this up in one of the VMRs. I know this because I learned it from our podcast, all those things. So that nostalgia, it's constant, like 24/7. I always remember. So today I thought that, well, after a long time, I'm getting a chance and the timings are aligned. So let me join this group. Let's see if something new we could learn today. And I also wanted to, give a huge shout out to Carly. Like I can't even imagine that how hard it must be for third-year medical students. Like they're not even MS4, they're MS3. They're in midst of their rotation. There are lots of things to do, assignments to do, didactics to do. And in between them, they are finding the time to present a case to the group that requires a lots of dedication, determination, and smartness. So thank you so much, Carly. Looking forward to learn from your case. And thank you, Dr. Singh, for this opportunity. Okay.
Awesome. So should we get the whiteboard up and get started? Okay. Carly, you could the first aliquot.
Okay, sounds good. So starting off with our chief complaint. This is a 60-year-old man who has a history of hypertension, gout, and GERD, who presented with 5 days of fevers, chills, generalized weakness, and fatigue.
Sure. Maybe I can start the discussion and then Dr. Singh can help us through. So this is a very common complaint that we often see, not only in the ED, but even on the floors and sometimes even when you are on the consult service. So how should we approach somebody who has fever, chills, generalized weakness, and fatigue? So if we kind of want to give a label to it, then all of this could be given a label of non-specific symptoms, like constitutional symptoms, so as to speak. And whenever we use the word constitutional symptoms, it reminds us that since they are constitutional, which means the basic metabolism of the body is affected, So it means that there could be multiple processes which could be affecting the body. It's not just one organ, it's just the entire metabolism of the body. And we also always talk about that how to approach the fever, right? So we have the I-made mnemonic. And if you think about the I-made mnemonic, you will realize that all the entities under the I-made mnemonic kind of affects the basic metabolism and cellular machinery of the body. And that's why they give rise to these constitutional symptoms. So what should we think about? So we should think about infections. We should think about autoimmune conditions, autoinflammatory conditions. Since the time course is acute, less likely to be malignant or neoplastic etiologies, but we should always keep them at back of our mind. Some endocrinologic conditions, and finally toxic or iatrogenic, which means the drug-related conditions. So first things first, that since the infection is something we have to rule out, how should we approach this? So there is a very nice schema on our website that how to approach the fever and how to link it with the infection. So usually we look for the localizing signs and symptoms. So do you think the fever is coming from the upper respiratory tract, which means something is in the sinuses, something is in the nasal cavity, something is in the pharynx or larynx, and sometimes even the head and neck infections in general, which means something in the neck, something in the ears or the eyes. Then we look at the lungs, that, okay, is it coming from the lung parenchyma? It is coming from the pleural space? Is it coming from the large airways or something from the pulmonary vessels? Then we look at the heart. So is it coming from the endocardium, myocardium, pericardium? Then we move downstairs. We think about liver, we think about spleen, we think about retroperitoneal spaces, we think about the intestine. Then we think about the kidneys and the ureters all the way down to bladder. So these are the common organs that we look for. Then what are the must not miss conditions? So head, right? So meninges, encephalitis, intracranial abscess, things like that. And after we have localized the source, what if you are not able to find any source? Let's say you get the x-rays, let's say you get the CT scan of the abdomen and pelvis, you're not able to find any localizing signs and symptoms. Then what you should think? So usually we think about the occult source of infection in the body. So we think about, okay, could this patient have endocarditis, which we are not just able to obtain on CT scans? Could this patient have some localized abscess somewhere or osteomyelitis, which is giving rise to all these signs and symptoms? So that is how we should approach the infectious part. Having said that, it's always important to look at the vitals as well, like how sick is the patient, because we have to make the decision that are we comfortable handling this patient on the floors, or should we think that, okay, this patient may require a higher acuity of care and should go to ICU, CCU, depending on what are the signs and symptoms. So getting the vitals, getting the drugs which patient is on, recent travel history, recent exposures to any other infectious agents, that should guide our discussion. So Dr. Singh, can you guide us more that how we should approach this problem?
Kirtan, that was such a thorough discussion. I think at this so early on in the discussion, I'm not going to generalize too much, but I think here what we do want to frame is fever. And I just love you went through I-made is an incredible mnemonic, not to just anchor in on infection here, but you can't just help but do your due diligence that there may be an infection in evolution in this patient here. So going through, like you just so eloquently sort of laid out in front of us, is all the possible infections, and also using this to guide your physical exam or directed questioning and also examination of the patient. So I usually the systems that I would entertain would be in this mnemonic that I do teach the students, GRUBS with a C. So GRUBS, GI, so it could be any sort of itis, so examining around the abdomen, R, respiratory, which could be pneumonia, empyema, and so on, U, UTI, or the urinary tract infections, B, bacteremia, so getting a blood culture, skin, soft tissue, the largest organ in the body, so definitely going head to toe. And then C, so what's interesting, I did discuss this with Saman a while ago. I sent him the sort of template for this, and he said, add C. I'm like, why? He's like, well, if you exhaust all those different systems and you don't have an answer, maybe take a look up at the head. And like you eloquently mentioned, if there's meningismus, although it's not, doesn't have great sensitivity specificity, but that does clue you in there could be something going on intracranially. So looking at all those systems, and Ravi says that in the hospital, these are the most common infections that you will see. I think it's prudent to really look through these infectious etiologies before you move on to maybe the other parts of that mnemonic and I-made. Back to you, Carly.
Yeah, that's a great discussion so far on what this can be. It's definitely broad symptoms at first. So yeah, as I mentioned, this is a 6-year-old man with a history of hypertension, gout, psoriasis, and GERD who presented on November 28th with 5 days of worsening lethargy, fever, and confusion. So the patient was traveling in Micronesia and returned 1 week ago on Sunday, 11/20, after doing a 10-day diving trip. And in Micronesia, he was diving twice a day for 9 hours a day, exploring like World War II wreckage sites on the islands. He stayed on the boat for 9 days and was consuming mostly packaged meats and fruits. He last dove on 11/18. He initially returned and was feeling fatigued, and he noticed that he had some ulcers and blisters on his feet that were swollen and painful. And then on Thanksgiving, so this is Thursday, 11/24, he developed a fever in the afternoon and began to feel very sleepy. On Friday, he developed excruciating pain in his left collarbone. It was a little swollen. He iced it, but he still had this neck pain. And the morning that he presented to the hospital, he woke up extremely lethargic and drowsy. He drank a couple of cups of tea, but then he rushed to the sink. He had an episode of MSS. He went back to the couch, and 2 hours later, he needed to use the bathroom for a bowel movement. But he had so much trouble ambulating. His wife had to help him to the bathroom, and he was so weak that he had to go down the stairs like on his buttocks. So he like was using his arms to help him go down the stairs. So he was starting to be very disoriented, having trouble answering some of the questions. So his wife decided to call 911. Some other symptoms that he endorses are gradually worsening generalized weakness, fatigue, frontal headache, clear rhinorrhea, sore throat, multiple episodes of epistasis. He had no new rashes or lesions, no chest pain or shortness of breath. He said that these symptoms really reminded him of a previous episode of decompression illness. So, that's when you arise from a depth too quickly. But he notes that throughout this diving trip, where he was diving very deep, like way past what's just considered safe, you do have to, decompress for a while. But he said he was very safely decompressing throughout the whole trip. And he notes that no one else in his travel group has reported becoming sick, and he's very good about taking all of his travel vaccinations. So going into his past medical history, I think we have almost everything there: hypertension, diabetes, gout, psoriasis, GERD. For his social history, he drinks about 3 alcoholic drinks daily. He works as an engineer. He has no smoking history or recreational drug usage, and he has 2 cats. His family history is non-contributory. For his surgical history, he has a atrial septal defect that was repaired with an occluder in 2012. He has no known allergies. And for his medications, he takes allopurinol, omeprazole, amlodipine, and simvastatin.
Singh, do you want to take the first step for this?
Definitely. It gets very exciting now that we have a patient coming back. Now we can utilize what we call the schema for fever in a returning traveler. So you have somebody who's come back from vacation in Micronesia. I'm not too well versed in what kind of things that could be out there, but then you've got this diving trip, 9 hours a day, and now having ulcers and blisters on the feet. So now you can't help but start thinking about things that the patient could acquire in water, especially with the skin being involved here. So what kind of infections that can be related to, water? Could be think about Mycobacterium marinum. You could also develop Vibrio, although that usually on the steps is associated with liver cirrhosis. But here we do have an immunocompromised state here with diabetes mellitus. So it's not unusual to develop lower extremity infections in a diabetic patient due to hyperglycemia, impairment of neutrophil, neutrophils attacking the infection or preventing infection. Also peripheral vascular disease as well, with less blood flow and allowing for harboring of infections or readily taking up of infections in the extremities. Other things that you can get from the water, so usually staph still can be acquired in the water as well. Strep, so beta hemolytic strep. But then you have to start thinking with these boils. What kind of things could develop boils? I kind of have to think about. I'm wondering if melioidosis could be something out there. And this patient is very toxic, right? He's got a lot of associated, as Keith mentioned, constitutional symptoms, emesis, feeling really lethargic and weak. We have yet to be given the vital signs, and I'm sure this patient is going to exhibit very, very toxic vital signs with fevers, possibly with volume deficit. Other things that could develop, I guess, Pseudomonas you can also develop in water as well. Notoriously on step 1, I always remember, is hot tub folliculitis, so something you can develop. And then we went through Mycobacterium, melioidosis, Vibrio vulnificus, parahemolyticus. And then I think there may be a few other mycobacteriums. I can't remember. What do you think, Ethan?
Yes, thank you, Dr. Singh. You almost covered all the bugs. And I also wanted to say that what a rich aliquot and what a nice way to present it, Carly. And also to Seema to encapsulate everything very nicely. So thanks for that. And as Ravi always tells us, that you have to think about the foreground and you have to think about the background. So if you look at the past medical history, the patient has psoriasis, patient has gout, and patient is on allopurinol. Now, why these three things are important? Because we have to ask ourselves that how bad is the baseline psoriasis of the patient and what kind of psoriasis is it? Because we know that psoriasis is a breakdown of the skin. And as Dr. Singh was telling us, that the patient was in the water for long period of time. So what if it's the breach of the skin which allowed those bacteria which may not have time to colonize, but which directly found a pathway inside the body because there was a break of the skin. And we know that sometimes people also have what is known as palmoplantar psoriasis. So often you find that on the palms and the soles, patient has these blisters, patient have these kind of erosions, ulcerations, which can also confound the clinical picture, and infection can certainly worsen. So that's the first point. We have to go back and ask that how is the baseline psoriasis? The second aspect of it, the allopurinol. Now, as we know that always when we are dealing with a problem, there is this issue, right? That, okay, is this the infection or is this the drug which is causing the hypersensitivity reaction? Now, as Dr. Singh said, that since we have to be cautious, that patient has lots of constitutional signs and symptoms, in fact, localizing to the head to a certain extent. So we cannot just say that, okay, this is due to allopurinol, but that is something that I would keep at back of my mind, because allopurinol is known to cause many hypersensitivity reactions, including aseptic meningitis and flare-up of psoriasis as well. So this blister on the feet, what if it's the psoriasis flare, and all this neck pain, all this headache and emesis if it's due to aseptic meningitis. So that's the first one. The second aspect, that why we have to think about the gout as well, because gout is a crystallopathy. And sometimes people can have deposition of the uric acid crystals in the cervical vertebrae. And that's also common in people who have calcium pyrophosphate crystal deposition disease. So we also have to ask that how good is the gout? Like, is it something which happens every now and then? Is the gout poorly controlled? So that's the one point. Now, having said all these things, what about the infections which Dr. Singh was telling us about? So I agree that things like Vibrio vulnificus, things like Mycobacterium marinum, then there are also other infections like Erysipelotrix rhiziopathy, Aeromonas, Plegiomonas, which can come from the water and which can cause these disseminated infections. There are two more things which we have to consider, that the water in which the patient was swimming, whether it was a fresh water, whether it was a salt water. Because if it's a freshwater lake kind of thing, and with these explosive cerebral symptoms, it's hard not to think about, amoebic encephalitis. So things like Naegleria fowleri, things like Acanthamoeba, things like Balamutia mentrillaris, because all of these things cause primary amoebic and some of them cause granulomatous amoebic encephalitis. And the acuity of symptoms in the exposure to water always makes you wonder, okay, that could this be this? So that's one part. The second aspect, which is kind of concerning, is that this patient has emesis, which is going on now for quite a lot of time now. Now, what do you make of vomiting, right? Either it could be just a non-specific sequel of any infection which you could have, but it also makes us wonder that what if patient has increased intracranial pressure? And then we start thinking about management more so than the diagnosis. What if the patient is on the verge of herniation because of the cerebral edema, and because of that the patient is vomiting so much? And it can happen in any conditions which affect the brain, like be it meningoencephalitis, be it brain abscess, or all these bugs which we talked about. And the epistaxis is also kind of concerning in a sense, because it makes us wonder, in the first helicopter we discussed, right, that what's the focal site of the infection. So now we are wondering about, okay, could this be rhinosinusitis as well on top of the meningitis? Because when you go inside the water, things can go directly into your nose with high pressures, and that is when you can get these infections. So we have to think about that as well. And there are some other rare bugs, but we should not go there as of now. For example, eosinophilic meningitis can cause classically this very drastic neck pain due to gnathostomiasis and angiostrongyloids. But as of now, we are more concerned about looking at the patient's vitals, physical examination, and do we need to send this patient to the ICU? And I would have very low threshold to get the ID on board and even neurology on board, so as they can guide us our decision making.
Yeah, Keith, I just want to add also, this patient with deep sea diving, I would anticipate this patient will be wearing fins, which are rather have a thick sort of composition, and they're usually plastic. So, and then divers usually use some sort of socks and have a rubber suit. And I great thought about acanthamoeba and Naegleria every summer. These harmful algal blooms, and in lakes tend to develop meningitis, serious adverse meningitis in swimmers. So something to think about if you do go swimming. Always make sure you pinch your nose and don't go down so the water can enter your nose. And within the change in the environment, we're seeing more and more of this growth in lakes. So something to be very careful about. But with swimmers, they tend to also have goggles which do pinch the mouth. But I'm not sure if this diver was just snorkeling or they actually were using oxygen cylinders. Do you know, Carly?
I think they were using full diving gear.
So you anticipate full body protection, but then you never know. There could have been an accident or piercing of one of the covers on the feet.
Yeah.
Okay, back to you, Carly.
Okay, great. Yeah, that's a great discussion. These are all things that we were thinking of, especially when we started talking about like the Vibrio and the Naegleria family. That's all things that we were talking about too with this patient. So going on to the vitals, the patient presented with a temp of 96.3 or 35.7. They had a BP of 148/74. They had a respiratory rate of 18, and they were setting at 98% on room air. For his exam, for his constitutional, he was tired appearing, aroused as to voice, but falling asleep frequently and answering mostly yes or no questions. He was also profusely diaphoretic. For his HENT, it was normocephalic, atraumatic. Pupils were equally reactive and round. Extraocular eye movements were intact. He had moist mucous membranes, and his posterior oropharynx was normal. For his cardiovascular, he had regular rate and rhythm and no murmurs. Pulses were equal in the upper and lower extremities. For his pulmonary exam, his lungs were clear to auscultation bilaterally, no wheezes or crackles. He was not in any respiratory distress. For his abdominal exam, his abdomen was soft, non-distended, non-tender to palpation. He did not exhibit any guarding. For his neuro, he was lethargic, oriented ×3, moving all extremities, no focal deficits noted. And for his extremities and skin, he had no lower extremity edema. He did have bilateral feet marks with ulcers and eschar. I do have some photos if you want me to share those. He also had significant tenderness to palpation of the medial aspect of his clavicle, with surrounding tenderness in the lower left neck and upper chest without any swelling, warmth, erythema, or wounds.
Carly, I made you a co-host. You can, I guess you can share screen and show us the pictures if you'd like.
Oh, good. I think you might have to stop sharing them for me to share. Okay, so here was this is his left foot. This is his right foot. And here's both of his legs.
Wow, incredible. So, Kirtan, you want to go first, or do you want me to?
You can go first, Dr. Singh.
Okay. Just looking at those pictures there, I think the last thing that we just left with looks like some of that has healed over. So he doesn't look very angry looking at this moment. And I see some mesh scars. I don't know if that's just the scabs developing over the lesions, but they don't look erythematous. They don't look like they're weeping. There's no abscess formation, vesicles. There's no purpura. The epistaxis was interesting. Keaton mentioned, I started to think about maybe a patient is developing coagulopathy. So purpura petechiae would be an ominous sign in this case. But what's interesting, somebody mentioned Rishma, who's also a former student of mine, had mentioned in the chat something very interesting, that if the ASD repair has something to do with this, maybe there was an endocarditis, so maybe there was an infection that started in the feet. Now the skin findings have healed over, but now the infection is continuing over. And as Kirtan had so masterfully discussed about gout, psoriasis, and so on, so the patient's predilection for illness is very high in this patient, especially with diabetes mellitus, is vulnerable to all sorts of things like streptococcal shock syndrome, staphylococcal shock syndrome, and so on. But the vital signs here do not really show a devastatingly ill patient. So you have to start wondering what could be continuing. The two cats we put in red there, that's kind of interesting. Is all of this a detractor and this patient could have just developed an infection from the cats? I'm not sure. Could this be just something, maybe it's all garden variety endocarditis here. And that could also manifest with all this multitude of different signs and symptoms. So at this point, I'm not sure where to go, but definitely I think the chemistry, CBC will help us at least. If it shows elevated white count, then we know we'll have to start some empiric antibiotics while we wait for cultures. And then also to see if there's any development during this patient's hospital stay, such as worsening of mental status, then we have to go look in the CNS, get an LP in that case. Not sure about imaging at this point, if it's necessary at this point, but the upper chest, tenderness to have palpation in the left side of the neck, that may need to be imaged. So I wonder if there's a lymph node that's there, if the bone there, the clavicle maybe, if infection has moved to that area, do we need to take a look at that as well? Those kind of would be two areas where I would probe deeper. What do you think, Kirtan?
I definitely agree with you, Dr. Singh, that we have to decide whether we need to get the imaging studies first or we can move directly to LP. And this aliquot again emphasizes that why it's so important to have the physical examination, because once you have that, you can go back to your HPI, you can piece apart the clues and try to figure out. So as Dr. Singh was telling us that what should we make of this tenderness to palpation in the left lower neck? Could we just say that, well, the patient has maybe some sort of meningitis and it's the spasm of the neck muscles because of the irritation of the meninges which is causing it? But then you also wonder that what if there is actually something going on there? So if you look at the structures from top to bottom, we think about, okay, could this be something in the skin or the subcutaneous tissue? Now, Carly mentioned that there is no evidence of erythema as such. So that definitely lowers the suspicion of something right in the superficial skin like cellulitis or something. But deeper structures like involvement of the fascia, the muscles, and the blood vessels is not off the hook. So if you think about the fact that the patient had sore throat and now the patient has left lower, neck palpation, tenderness to palpation, then what's going on there? So firstly, talking about the sore throat, this headache and all the things which have been going on. So we always say that think about exotic infections, but common infections are always also likely in patients who are immunocompromised or who have all other risk factors. So if you have sore throat and if you have these meningeal signs and symptoms, you immediately think about, okay, could this be streptococcal meningitis, right? Could this be Neisseria, Listeria, all the common things of meningitis. But you also start wondering that what could be the complication of having a sore throat. There are suppurative complications. You can have parapharyngeal abscess, you can have retropharyngeal abscess, you can have internal jugular vein thrombosis, which can cause Lemierre syndrome, like thrombophlebitis kind of picture. And sometimes that can also migrate upwards and involve the cavernous sinuses. So it's always nice to have, a fundoscopic examination to make sure that patient's papilledema is not something that we have to consider because of the involvement of cavernous sinuses. So these are the things that we have to consider, that how to link the sore throat into our picture. And on the examination part, I agree with Dr. Singh that it doesn't look so inflamed as of now. Maybe we are in the later phases of infections when things are scarring and more in the healing phase. We did see some necrotic ulcerations or eschars. Now, it's hard to just say that what infections can cause it, because in right setting, any infection can actually cause those things. So, for example, if you have sore throat and then you always worry about, okay, patient has been in the water, could this be related to leptospirosis or hantavirus? And with epistaxis in picture also, you start wondering that if the patient has coagulopathy, like maybe DIC or purpura fulminans, then again, all these infections like Neisseria meningitidis, rat bite fever, leptospirosis, hantavirus comes at the forefront, because these are the infections which are likely to cause DIC. But common things common, if you think about it, any bacterial infections, if you have the sepsis, then they will cause DIC and can cause epistaxis. So that is something that we have to be mindful about. And regarding the imaging study part, now it's hard to say, but since the patient is, kind of lethargic, kind of tired, and although patient is oriented ×3, but we are still not getting that flavor, that he's completely himself. So at least we can get the fundoscopic examination to make sure there is no papilledema, or get a non-contrast CT scan of the head. And then we can move ahead with the lumbar puncture. And meanwhile, we can also get the CT scan of the thorax, abdomen, and pelvis, blood cultures, urine cultures, get the basic CBC, BMP, LFTs, RFTs, so they can guide us at how to move ahead.
Yeah, Ketan, I just want to weigh in. It's interesting, a halfway point, we're generating much more or many more hypotheses than refining some of the hypotheses we had early on. So the journey's just been incredible. This is a textbook of infectious disease that we sort of gone through, especially with the chat. I love, Shame had mentioned, I think Ravi's still here, but he presented, or somebody presented a patient that came in with a stiff neck. So in the ER, Ravi had a patient with a very stiff neck, and we were all sort of enthralled and engrossed in that case. And it was just amazing to figure out that it was CPPD, and it was CPPD of the C2 vertebra, and I just had no idea that something could cause something so excruciatingly painful in a patient. So it was good to sort of revisit that. But yeah, Eschar, that was interesting. It did kind of cross my mind, but you mentioned, if I remember, Eschar causing infections, Pseudomonas comes to mind, and ecthema gangrenosum. I know some of the rickettsial diseases could do that as well. And then skin conditions associated with autoimmune phenomena, I guess, maybe pyoderma. I know maybe less likely though, but calciphylaxis can also have an Eschar-like configuration, but I'm not quite sure. Maybe it's just healing. And like you had mentioned with DIC and so on, maybe the labs will help us. Any infection could culminate in a systemic response like DIC. So we'll see what the labs show. Back to you, Carly.
Yeah, great points. I think the labs might show a couple of things. So starting with the WBC, it was 19.66. Hemoglobin was 14.9. Platelets was 101. And for the chemistries, we had a sodium of 133, potassium 3.7, a bicarb of 21, a BUN of 17, creatinine of 0.9, glucose of 294. Let me give you the calcium. Calcium of 9.5. And then for the AST and ALT, he had an AST of 58, an ALT of 28, and he had a Billy of 2.4, and he had an albumin of 3.7. For his phosphorus, that was not initially on his initial labs, and magnesium was not on his initial labs either. Okay, do you want to pause for discussion before I do the imaging?
I think so. Kirtan, do you want to start?
Sure, we can have a discussion here. So Dr. Singh, maybe we can briefly discuss these findings. Of course, nothing is striking here, but we can discuss briefly and then we can move to the next aliquot. So we have thrombocytopenia and we have neutrophilic leukocytosis, mild hyponatremia, hyperglycemia, and hyperbilirubinemia. So how to make sense of all of these things? So first things first, we know that this patient is very sick. Now, often when you have inflammation raging in your body, be it because of sepsis or underlying malignancy or any other toxic conditions, often the bone marrow will be suppressed to variable extent. So you will find this often that when you are working in the ICU, you will have lots and lots of patients who have mild thrombocytopenia, maybe mild leukopenia, and then it will eventually improve. So one way to think about it is that it's the inflammation which is suppressing the bone marrow and causing the thrombocytopenia. And to be honest, in our case, thrombocytopenia is not very severe. It's just mild thrombocytopenia. But you also have to take a step back and realize that, okay, that's one hypothesis. But what if thrombocytopenia can actually guide me in making the decisions? So what are some of the common infections which can cause thrombocytopenia? So if we start with the atypical infections, so things like Legionella, Chlamydia, Mycoplasma, Listeria, these are the common bacterial infections which can cause thrombocytopenia. Then if we move towards the tick-borne diseases, so as Dr. Singh was telling us in reference to the eschar, that Ehrlichia, Anaplasma, Rickettsia can cause this. Then other infections, so for example, leptospirosis, which are water-related infections, hantavirus can also cause thrombocytopenia. And lots of viral infections too, like influenza can cause it. So these are the infections which we should keep at back of our mind in case the thrombocytopenia continues to worsen and doesn't improve. At this point, the suspicion for DIC as such is low because of the fact that hemoglobin is normal and platelet counts are not that bad and patient is not looking sick, to be honest. So the concern for DIC is less. The leukocytosis part, again, there is leukocytosis, but it's not like drastic leukocytosis. So it can be due to inflammation, can be due to number of infections. So it doesn't help in zooming in further in the differentials. Same is true for the sodium as well. Now, sometimes we learn that, okay, people who have Legionella can have meningitis, can have severe hyponatremia as well. But this hyponatremia is very mild, and mind that patient has been vomiting. So patient is, of course, volume depleted. So that itself can cause hyponatremia. So that too is something that we cannot anchor onto. Regarding the hyperbilirubinemia part, it is certainly interesting. And it is interesting because we are discussing in the first aliquot itself that we need some local source of infection, right? So now we have a signature coming either from the liver or from the peripheral blood in the form of hemolysis. So if this is indeed hemolysis, then you start thinking about the infections which can cause hemolysis and can also hit the brain. So things like malaria, babesia, and in the right setting like Bartonella bacilliformis, if the patient is from those countries, then we think about it. But if it is direct hyperbilirubinemia, then the focus shift again to the liver. Now, based on the AST, ALT, ALK-Phos, and GGT, we are not getting any classic signature of hepatic abscess or hepatic infiltration by any infectious source, but it is certainly possible that we are early on in the stage of infection and liver is just getting started to involve. And maybe that's why you have just high bilirubin and mild transaminitis, but nothing else. So getting imaging of the liver, like ultrasound of the liver, and ideally CT scan of the abdomen and pelvis, because we are honestly concerned about this patient, should guide us that what to make of that bilirubin. So Dr. Singh, what do you think of all these lab findings?
It's an incredibly masterful discussion of the labs. I'm just so impressed with the year that you've had under your belt and how you have associated all the clinical experience and partnering that up with your book knowledge or your general knowledge and how you've advanced your ability to sort through a lot of the information with cases there. It's just amazing how much or how far you've progressed. But I really don't have much to really add to this. I think the plot has certainly thickened. The white count now is directing us towards definitely an infectious etiology. Which infection, I'm not sure, but definitely imaging will help. Maybe there's a source somewhere that we can maybe put a needle and get some maybe material that we can culture, or possibly there's a culture that may just unmask something that may be going on in the patient here. Also, yeah, I think it's interesting with the total bilirubin if it is mostly indirect. I don't know. Do you know, Carly, if it was indirect or mostly direct?
I can take a quick look.
But if it is indirect, it just does support possibility of hemolysis and all of the wonderful infections that you had mentioned. And now some of you might be looking, wait a minute, the hemoglobin is normal, but this patient, and especially this patient's highly inflamed, and usually by now you'll have anemia of chronic inflammation, and also this hemoglobin should start to trend downwards. But with the hyponatremia, this patient may be dry, and the emesis the patient was having, and possibly not eating for a few days, traveling, and so on, does take a toll on your body. So this could be some mixture of hemoconcentration along with dehydration. So yeah, it's sort of like, which one do you balance? Which one is predominant? I guess more dehydration. But it'll be interesting to see direct, so 1.1 indirect. So it's a mix of direct and indirect. So there may be also a signature, like Kirtan mentioned, in the liver. So we'll see what the imaging shows then. Back to you, Carly.
Mm-hmm. Yeah, so he had an EKG done. It was normal rate and rhythm, 84 beats per minute, normal axis. He had a long QTC of 571. And he showed no ischemic ST or T segment changes. For his chest x-ray, it showed interstitial and consolidative opacities in both lungs, greater in the perihilar region on the left side. It showed no pleural effusion, no pneumothorax.
Carly, how much more data do we have before we get the answer? Because we are, kind of nearing the end of our session.
Yeah, okay. I'll jump into, we talked a little bit about the hospital course that the patient underwent. So important update at 4 p.m., the patient had an acute change in mental status. He became more altered, not turning his head to the left or following any commands. He had a stat CTA head and neck down, which showed no large vessel occlusion. He also had a stat CT chest, ab, and pelvis, which showed no acute abnormalities. And then around 5 p.m., the ED providers noted that his gaze was deviated to the right, and he started developing semi-rhythmic shaking of the lower legs. No facial twitching, eyes remained deviated to the right. He was given Ativan and Keppra, and he had an MRI brain VAT protocol done, which showed no acute infarct. His repeat neurological exam at this point showed marked nuclear rigidity. His GCS now was down at 9. So we also did that right upper quadrant ultrasound, which we showed hepatic steatosis superimposed on chronic hepatocellular disease. So in the setting of all these changes, he was subsequently intubated and transferred to the NCCU.
Wow, those are remarkable developments, and really does help us focus in on where the issue lies. So this patient having acute change in mental status, this relating now this infection to the CNS system, and then having what looks like a seizure, and then the right upper quadrant ultrasound doesn't really show us much of this chronic hepatic steatosis. So that signature that we were looking at, I think we can sort of push to the side and now focus in on the CNS. So I think it is vital. What do you think the next step will be, Kirtan?
Yeah, I agree, Dr. Singh, that things are getting way ahead of us. And Carly, just to make sure I didn't miss it, that MRI didn't show acute infarct, but did it show any other sort of mass occupying lesion?
No.
Okay,
No lesion.
I see. All right. Perfect. Perfect. So starting from the top, like just the important finding on EKG is that the QT is prolonged. Now, if we think about the QT prolongation, there are many things in the hospital which can prolong the QT, like simple electrolyte disturbances like low magnesium can cause it. You are like literally vomiting through and through, which can cause low magnesium and can cause it, and low potassium can cause it. That's fine. But if you think about the severity of it, this is like severe, as she said, that is above 550, which means it is way too prolonged for anybody. And it can be important in right context because any intracerebral catastrophe, be it hemorrhage, be it meningitis, encephalitis, any infection can alter the autonomic tone of the body. And often we find that people who have, let's say, subarachnoid hemorrhage can end up having QT prolongation, can end up having Takotsubo's, can end up having myocarditis, all those things, because it's all about the sympathetic surge, which alters the ventricular depolarization and repolarization. So the fact that QT is severely prolonged also makes us wonder that, okay, is this a signature that something is really bad in the head going on? So that's one part. Now going to the chest X-ray, this interstitial consolidations in both lungs. So first thing we have to worry about is that, could this be pneumonia? Now, based on the fact that whether there's typical organisms or atypical organisms, we often try to, classify them that, okay, there's consolidations, maybe more infiltrates, so it could be typical or atypical. But in reality, when patient is so sick, you don't have time to think about that, right? You just go for the cultures, you try to find out what organism it is, you start broad spectrum and just treat everything which is there. But we also have to understand that what if this is not any infection in the lungs? It's just the sepsis or ARDS which is causing this pattern, because we often see that the people who have fluid in their alveoli, the pulmonary edema can really cause anything. It can look like infection, it can look like diffuse alveolar hemorrhage, and so many things. So we have to ask ourselves that, is this infection or is this just ARDS or systemic cytokine storm which is causing that chest X-ray pattern? And now this gauge deviation, right rhythmic shaking, makes us wonder that, oh, there is something wrong in the CNS. But well, the MRI didn't show any focal abscess or focal mass. So what should we make of it? So now our best bet is that since we have ruled out the raised intracranial pressure, we can safely go ahead and do the LP. The patient's platelets are fine. Patient's coagulation markers are fine. So there is no apparent contraindication. We can get the LP and try to find out what organism this is, because certainly it's not involving the parenchyma as such. It looks like it's the meningeal irritation which is causing these seizures, which can certainly happen in people who have meningitis and no abscess or no encephalitis. So that is our main concern as of now. Get the LP, find the organism which is causing all this.
Yeah, I think now the organisms that you mentioned eloquently before, the Balamuthia, Nigelera, can't even pronounce it, and Acanthamoeba, Rhizopus, and a few more definitely have my curiosity. And so going for the LP definitely will give us the answer. So Carly, back to you.
Yeah, absolutely. So accordingly, he was started on ampicillin, cefepime, acyclovir, vancomycin, and flagyl. Once he was sedated in the NCCU, they were able to do the CSF cultures. They also did blood cultures, and these all revealed group B strep, consistent with group B strep meningitis. His antibiotic coverage was subsequently narrowed to penicillin G.
Holy cow. Group B strep. So it wasn't something esoteric like those other organisms, but the good old group B strep. Now, it's so interesting. Why group B strep? What I do know, I did have a patient like this that suffered devastating diffuse disease from group B strep. So there has to be some sort of immunocompromised situation. But if you do look it up, diabetes can be one, liver cirrhosis, maybe renal disease. So you have to have a predisposition for it. You don't just get up and acquire group B strep. In obstetrics, you do learn about group B strep and the birth canal and giving prophylaxis, but group B strep can cause devastating disease through bacteremia, and it can actually affect a multitude of different organs. So I remember sitting in on an autopsy where they found group B strep in myocardium, liver. It just wreaks havoc on all systems of the body and can cause devastating illness. So no wonder this patient was very ill. And I'm just gobsmacked. What a remarkable case, and lots of learning from Kirtan there. You just taught me a lot. I don't walk around thinking about Nigelera or Acanthamoeba, but it'll definitely be on my mind. And thank you very much, Carly. This is such an exciting and such a case that you've so eloquently delivered. And I'm just astounded how well you presented this case. So I appreciate it. Kirtan, any reflection?
Yeah.
Go ahead,
Awesome.
Kali.
I was just gonna add one other big event that happened in the rest of his hospital course. So he was diagnosed with group B strep. We converted his antibiotics to the appropriate coverage. But we got a repeat MRI brain actually on 12/2, and we had been discussing his atrial septal defect and the possibility of endocarditis, and this comes back into the conversation now. So his MRI brain on December 2nd showed multiple diffusion restricting foci, predominantly in the bilateral frontoparietal lobes and temporal lobe. So they did a TTE first, which didn't show any concerns for any like septic emboli. But then the neurology team, which is what I was on at the time of this case, had a really high suspicion that there was something going on with his heart. So on 12/7, we ended up doing a TEE, which showed the atrial septal occluder device with a highly mobile echo density attached to the left atrial aspect of the device, which was consistent with the vegetation. So we subsequently consulted cardiothoracic surgery, and on December 15th, he subsequently underwent explants of his ASD occluder device, and his patent femoral valley was fixed by cardiothoracic surgery. So he had to undergo subsequent operation because of this endocarditis.
Incredible. I think Rishma essentially in the beginning had put in there ASD, I think maybe endocarditis. So good thought there. Yeah, good thought. Excellent. Yeah. And just incredible. Kirtan, any thoughts?
Sure. So thank you so much, Carly. And I also wanted to echo the thought which Dr. Singh put forward, that not only the case was very nice, but the way the Carly presented it, all the details in a very structured manner, and how to give the right piece of data at the right time. So thank you so much, Carly, for that. And Dr. Singh, this is where these cases get so humbling. And that's why we always remember what Ravi says, remember when we were discussing the physical examination part, we said that we can think about all the esoteric infections, but if you just think about the sore throat, then we start with staph, strep, then we talked about Listeria, Legionella, and then Fusobacterium, the classic organism which causes strep throat, right? So we were right in that sense. And regarding the ASD part and endocarditis, so going back to the first aliquot, we discussed that if you get the CT scan of the abdomen, pelvis, and if you don't find anything, so then you start thinking about, okay, could this patient have occult abscess, osteomyelitis, or endocarditis? Because CT scan won't pick up endocarditis, CT scan won't pick up osteomyelitis all the time, right? So that was the first concern that we had. So now we have a closure on that it is so nice to hear that the team went ahead and get the transesophageal echo, and it didn't just stop at the transthoracic echo, which is good. And sometimes it does happen that people who have this group B and group C strap, they often have either intrapulmonary shunts or intracardiac shunts, and they end up getting numerous brain abscesses, which can explain all the findings. And it's also important to know that the patient had diffusion restriction affecting the temporal lobes as well. Now, the reason why it is important, because if you look at the literature of the people who have intracranial catastrophes involving the temporal lobe and then the cardiologic complications, then you will find a strong link. This is because in the temporal lobe, we have the sites of the autonomic nervous system activity. So you have the limbic system, you have the amygdala, you have the hippocampus, and on the right side, you have the insular cortex, which also is one of the known sites for the autonomic nervous system. So all those can cause the cardiac arrhythmias and QT prolongation as well. So having had the imaging studies not only helped us to find out the root cause of everything, which was the ASD, but it also helped us to figure out that, okay, what was going on in the heart as well. So the whole puzzle kind of, puts in the pieces. So that's so nice to learn from you, Carly. Thank you so much. And thank you so much, Dr. Singh, for helping us through, and looking forward to the teaching points.
A wonderful case, Carly, and amazing discussion, Dr. Singh and Kirtan. So I'll divide the teaching points via according to HPI and physical and labs. So we started with a patient who had fever, chills, and weakness. So it was pretty unspecific. And when we have these constitutional symptoms, The differential is pretty broad, and the mnemonic to remember it is the IMATE: infection, malignant, autoimmune, endocrine, and toxic. Fever is also not specific, but we can further push our HPI to determine, to find out more localizing symptoms that will further guide our PE. And it's also crucial to determine very early on how sick the patient is via the vitals and his travel history, etc., to like see where to admit them next. Dr. Singh mentioned a very important mnemonic here, GRAB SC for infections in the hospitalized patients is GI, respiratory, UTI, bacteremia, skin, soft tissue, and intracranial. And in the travel history, you found out that the patient traveled recently and he did some diving, and this further orients us to infections related to diving. It can be Mycobacterium marinum, Vibrio, Pseudomonas, Acanthamoeba, and then we found out that the patient has psoriasis, gouts, diabetes mellitus, and all of this makes them more prone to developing lower extremity infections. Psoriasis because it will make their skin barrier more prone to lacerations and breaches. And Kirtan brought up a very important point concerning the allopurinol and the gouts. Allopurinol can cause hypersensitivity reactions, and it's been documented that it can cause aseptic meningitis. That was also an hour differential for this patient. And gouts can also cause the neck pain and the meningitis-like symptoms via the deposition of crystals in the vertebral column. Another important symptom that we thought about was the emesis, and it can also be due to intracranial hypertension, and that can be caused by meningoencephalitis, which makes it very important to do the CT before, to do the imaging before the LP. And then Carly showed us the image with the scars and the ulcers on his feet that were pretty healed, and the differentials for scars are calciphylaxis, rickettsia, ecthyma gangrenosum, and anthrax. And then we found out that the patient has some QT prolongation, and we saw that the QT prolongation can be due to either the electrolyte disturbances or CNS disturbances, like especially those involved in the temporal lobe, like Kirtan said. And then we found out that the patient has group B strep meningitis, and in this type of patients, we should always look for an underlying immunocompromising condition like cirrhosis or diabetes mellitus, psoriasis, like our patients has them. And yeah, that's it.
Incredible, Umayma. Great teaching points there. Thank you for wrapping this up, and appreciate again Kirtan for just jumping in and discussing and just sharing so much of your wisdom. And Carly, again, it's an absolute banger of a case, and I just learned so much. So I'll definitely be reflecting and maybe talking with you about this afterwards. So thank you everybody for coming on, and please do come tomorrow. We have the marvelous Charmaine and Jack discussing a case. So see you there tomorrow. Take care. Have a great rest of Tuesday. Bye.
Thank you so much for having me.
Thank you.